Good morning. Great. All right. We'll just give it a moment so we have a full quorum and we'll get going. Can you guys hear me okay?
Yes.
Thank you. Excuse me. Okay, I think I see I think our two first year fellows are here. Tulsi's here, Dave's here, Maya's here. I don't see Ivana. Molly is here. I might as well get going. Okay. All right, so apologize, we've missed a few the last week or two. Haven't been 100%, still not, but trying to get them in when I can, when I feel up to it. So today we're going to do what I try to do at the beginning of the year, which is to review a drug and then one or two unknowns. So today we're going to talk about Flecainide. The brand name of Flecainide is Tambacor. And Flecainide is a 1C agent. It's a sodium channel blocking agent of the 1C category. And clinically, we use this agent for the treatment of SVT, mostly in pediatrics, particularly patients who have either AVNRT or ORT or WPW. It can have direct effects on the His-Purkinje system, and it also can have direct effects on accessory pathways. Certain forms of VT, it can be useful. For example, RV outflow tract VTs, it could be helpful for treatment, but as we'll see in a moment, it's not a great agent for treatment of ventricular arrhythmias in the setting of a myocardial ischemia, which is not very common in our practice, but we do rarely see patients who have myocardial ischemia, either from congenital heart disease, like an anomalous coronary, or iatrogenic. And that's because of the so-called CAST trial, or cardiac arrhythmia suppression trial, which we'll review in a moment. And then finally, a more novel usage of Flecainide in the last decade has been for the use of CPVT, patients who are not good candidates for beta blockade, which is the standard treatment for CPVT, or patients who have failed beta blockade or can't tolerate it for some reason. Flecainide is often used as a second agent or maybe as a combined agent. Now, this is an important trial, the cardiac arrhythmia suppression trial, to review. And the reason that it's important is because people comment on it all the time. This was a double-blind, randomized controlled trial, which was really designed to test the hypothesis that suppression of PVCs with class 1 antiarrhythmics after an MI would reduce the incidence of sudden death. So you have to understand that when this study was done in the 1990s, early 1990s, there were very little data actually on what was effective in helping patients. And as you probably know, when people have a myocardial infarction, the most common reason that they die is because they develop ventricular arrhythmias related to it. And so in an era when they didn't really know what was effective, what was not effective, it was before the era of routine defibrillators, cardiologists would very commonly use pretty much anything to treat these arrhythmias. And as you would imagine, if you had bad arrhythmias, they would go up the ladder and something like Flecainide would be used. So this was 1,700 patients in 27 centers over an 8-year period. And what they found was that it was true that if you gave them 1C agents like Enconide, Flecainide, or Miracicine, the first and last no longer available, they did actually reduce the total number of PVCs. However, they were very pro-arrhythmic, and actually, on average, patients who were on Flecainide were more likely to have an arrhythmia-related death. The total mortality was much higher on both Flecainide and Enconide at follow-up of 10 months, and the study actually was ultimately concluded. And so for that reason, Flecainide is never, ever given to anybody in whom there is a possibility that there may be coronary artery problems or concerns. Now, there are obviously exceptions to that rule, but as a general rule, you would never give Flecainide to someone who has possibility of a coronary issue because of these adult data. Now, maybe in pediatrics, there's absolutely no relationship to what we see and do, but I think that basically, as is often the case in pediatrics, we often use our adult data to inform our decisions. And so basically, although Flecainide is used very commonly in pediatrics for the treatment of arrhythmias, it's extremely important to remember that it should not be used for this. And it's also important to remember that, you know, there's a lot of negative press about Flecainide. If the average patient does some reading, they're going to come across something to the effect that it causes more arrhythmias. And you need to remind the patient that this is based on adult data in men and women who are having myocardial infarctions, which is very, very different, obviously, than pediatric patients. So again, it's used for AVNRT or ORT because of its direct effects on his Purkinje system and accessory pathways. Some RV outflow VTs would respond, although again, we would normally start with something more simple like a beta blocker for that. And again, not used for ventricular arrhythmias in the setting of myocardial ischemia because of the CAST trial that we just reviewed. And then again, as I mentioned earlier this morning, Flecainide inhibits the release of the cardiac ryanodine receptor-mediated calcium Ca2+ channels, and it's therefore believed to medicate the underlying molecular cause of CPVT in mice and humans. And so many cases and examples of patients who were very bothered by arrhythmia who were very well treated with the use of Flecainide, but again, on a case-by-case basis. And it blocks the sodium 1.5 channel in the heart, causing a prolongation in the cardiac action potential. Again, the greatest effect is on the his Purkinje system and ventricular myocardium, and it causes, it's important to remember that it can cause a reduction in ventricular function. So in a person who has a primary cardiomyopathy with depressed function, this may not be an excellent agent because it may make the function even worse. So that's an important distinction. In other words, if somebody has a tachycardia-induced cardiomyopathy where the actual arrhythmia itself is causing dysfunction, Flecainide would not be a bad idea. It would be reasonable. But if somebody already has pre-existent bad function because of a primary myocardial disease, Flecainide likely is not an optimal agent because it may, in fact, worsen heart function. Take someone who is balanced in heart failure and make them worse. Flecainide has this characteristic that's referred to in the pharmacological world as use dependence, meaning that it works better at faster heart rates. And so some people would say it's better at stopping an arrhythmia than preventing one. So, for example, some of you may be aware that in the world of adult cardiology, there are patients who have rare intermittent atrial fibrillation. And one of the therapies that are medical therapies for AFib is a so-called pill in a pocket approach, where a patient is given, say, 300 milligrams of Flecainide to keep in their pocket in the event that they have AFib once in a rare while. It's been demonstrated in studies to be an effective therapy for some patients. So that would be an example of where they're taking advantage of the use dependence of Flecainide. Okay. I just want to see here. All right, we have a nice quorum here. Okay. The metabolism, it has a very high bioavailability. The plasma half-life is about 20 years in adults, 20 hours in adults, and shorter in children. And it takes about 3 to 5 days to reach a steady state, which is the reason why when we start this medication, which is almost exclusively started in the hospital, on telemetry follow-up because of the possibility of proarrhythmia. We would typically watch a patient for a minimum of 3 days to confirm that it is not causing arrhythmia in an individual patient. It is mostly renally excreted and so has to be adjusted for renal dysfunction, but there's also some liver cytochrome P450 dependence for excretion. And so you really need both liver and kidney function to be on this agent. Very important drug interactions. Amiodarone will raise flecainide levels. This is a very, very important interaction. So patients who are on amiodarone should be dosed with very low doses of flecainide. Effectively, it will be a very high dose. Some of you, I'm sure, already have seen that we've had an occasional patient who's needed the combination of amiodarone and flecainide, typically babies who have very difficult to treat complex arrhythmias. We always start at very, very, very low dose flecainide because effectively the dose is much higher because amio raises those levels. And digoxin's interaction, flecainide may raise dig levels. And so if giving digoxin at the same time in someone who's on flecainide, you would want to lower your digoxin level as well. So these are two very important drug interactions. Virtual guarantee that one or both will be on your board exam someday in the future. So keep that in mind. Okay. Dosing. So generally speaking, the dose of flecainide is about 80 to 160 milligrams per meter squared per day. And flecainide in small children, really up till about 12 or 13 years of age, should be given Q8. Now, if you have a patient in whom you have a non-life-threatening arrhythmia, it's not unreasonable to try Q12, but pharmacologically, it really doesn't make much sense. In adults, the starting dose is 50 milligrams twice a day, BID, and you can treat up to 150 milligrams BID, which would be considered a very high dose. The toxicity, flecainide causes QRS prolongation as well as PR interval lengthening. So when a patient is started on flecainide, every day we obtain a 12-lead EKG, and normally we're looking at the QT for most of these toxins that we give children for arrhythmia, but the very important thing is to look for QRS prolongation. So typically, we're looking to see, is there a new bundle branch block that was not present previously on a patient's electrocardiogram? And then if you're seeing PR interval lengthening, chances are you're probably high in your level. Now, you can get levels of flecainide, but I've never worked in a place where it takes less than a week. So generally speaking, we don't usually measure flecainide levels in most kids. Instead, we look for evidence of both efficacy in the absence of toxicity when we're practically dosing it. Flecainide toxicity can be enhanced by low potassium levels. So you're going to want to make sure that the electrolytes are normal in the patient. And if a patient starts having ventricular ectopy, suggesting that it is pro-arrhythmic in an individual patient, the treatment, first of all, the most important treatment is to stop the flecainide. And then various different reports suggest giving sodium chloride, magnesium, calcium, epinephrine, and even the use of intralipids has been described to sop up flecainide that may be in the bloodstream, in the plasma. So, and it's usually, again, started in the hospital on telemetry because of concerns of proarrhythmia. One of the most serious concerns about flecainide, and one of the reasons why, in general, it would not be a first-line agent for treatment in small children, is because flecainide doesn't come as a solution made by the manufacturer. It needs to be compounded by a pharmacy. So first of all, of course, there's the complexity of finding a pharmacy willing to do that. But assuming that that's not an insurmountable problem, the real issue is that there are many, many examples of children, small children, getting overdosed with flecainide because of inadequate mixing of the solution. So patient gets too little flecainide at the top of the bottle and gets too much flecainide dangerously at the bottom of the bottle. So we always remind parents when they're sent home on flecainide to shake the bottle aggressively before every single dose so that it is as well mixed as is possible. That, of course, causes lots of bubbles to form in the medication, and then the parent wonders whether they've given enough or too little. But it generally it's an agent that has been associated with a lot of proarrhythmia that can be very, very life-threatening. So when in doubt, give too little, not too much. And always have to remind the patient family to really aggressively shake that bottle. And the person who is giving the medication probably should be the same person or two people always, never. That job should not be just handed around to different people because it is so potentially dangerous. Excellent agent, works very well for certain arrhythmias, but it's particularly effective also, I didn't mention this, for automatic tachycardias such as ectopic atrial tachycardia, another SVT for which it's used. But again, you have to be very concerned because it's given as a solution compounded by a pharmacy. Also want to make sure that this is one of these agents where it's very helpful for the parent to bring the compound from the outside pharmacy to the hospital before the patient is discharged to make sure that the concentration is correct. It's not uncommon for one pharmacy to mix it in one way. I'll make this up, say the hospital may mix it 10 milligrams to a milliliter. The outside pharmacy may make it 5 milligrams to a milliliter. And it's very, very important that we send the patient home knowing precisely how much medication they're taking. And a very serious conversation is always indicated when giving this medicine to a young infant, to the family, to explain to them the obvious benefits of it, but the potential risks and the critical importance of giving it properly. Any questions about this?
One quick question. I feel like you've said this before and I forget, but for kids on like tube feeds or something, that like continuous feeds, for example, I know that you've talked in the past about recommending like holding it for like holding the feeds, for a certain amount of time before and after giving the medicine.
Yeah, I mean, usually we would say about 1 to 2 hours before or after. I'm glad you brought that up, Molly. Milk can reduce the efficacy of Flecainide. And so that's right. You want to try to give it to a baby on an empty stomach. So you're going to want to stop the feeds a minimum of an hour before and for an hour after to allow absorption of the medicine. As we discussed, it's very well absorbed quickly, but that could explain bad efficacy of the agent, and it also could explain why people sometimes get overdosed because they are essentially getting different doses each time they're dosed if they're being given sometimes with feed, sometimes without. It's a very important point. Thank you for bringing that up. Any other questions? Okay. All righty. So we have here, now we're going to go into our potpourri portion of EP conference, which is mostly what we do here. And so we have here a 2-week-old who's in the emergency room. The family says that child has been spinning up her feeds for the last 24 hours and has been very irritable. And child looks a little bit gray in the ER, is crying. So, Christina, what do you think is going on here? And in terms of diagnosis, and how would you treat this patient acutely? And then we can talk about chronic.
Is the patient having SVT?
Are you telling me or asking me? Is this Jeopardy where we answer our questions in questions? What is SVT? Yes, this is a form of SVT. It's how do you know that though, or why do you say that?
Looking at it, it looks like the patient is tachycardic. With a heart rate.
So let me ask you a question before you go any
yes.
further. Does it look like the patient is tachycardic, or is the patient tachycardic?
The patient is tachycardic.
Okay, let's be definitive in our comments here.
Yes.
And what is the heart rate?
It looks like the heart rate is about 200.
You think it's that slow? How many boxes do you think it is?
Or one. So one big box,
right?
5
So
small ones.
So that means the cycle length of the tachycardia is 200 milliseconds, right?
Yeah.
So how
Yes.
do we convert the cycle length to a heart rate?
You multiply times 0.2, so it would be 300.
Right. So typically what we do is we divide 60,000 by the cycle length, will give you the heart rate. So actually, it's very important you get the heart rate right. Okay. So you
Mhm.
originally said it was 200, but it's really 300, right? It's
Mhm.
closer to
Yes.
300 beats per minute. So that's important, right? Because in 2-week-olds, a heart rate of 300 certainly sounds like it would be some form of SVT, right?
Yes.
How fast is SVT in babies? Usually, it's usually about 280 to 320, whereas in like 12-year-olds, it's like 180 to 220. So it's literally like 100 points lower, usually. Okay, is this a narrow QRS or a wide QRS tachycardia?
A narrow QRS.
Okay, and is the axis of the QRS look like, does this look like it's going down the AV node in a 2-week-old?
Yes.
Yeah, right. It's a little bit of a rightward axis, but for
Mhm.
a 2-week-old, that would be considered, a
Yep.
reasonable axis.
Mhm.
Now, if I just said to you, you have a 2-week-old who's in SVT in the emergency room, even without looking at the electrocardiogram, what are the number one and number two most likely diagnoses that we would expect to be in? So in other words, let's say you're the attending at home, I'm the fellow. It's 1994 when I was a fellow. There is no cell phones, so there's no way for me to send you a picture of the EKG. Your fax machine at home is not working, so I've just described to you as the attending that I have a narrow QRS tachycardia with the usual axis at a rate of 300 beats per minute. So as the attending at home, what are you thinking is the most likely etiology of this SVT?
I'm not sure actually.
Well, I'm asking you basically what's the differential diagnosis. So I'm gonna phone a friend here and let's see if Dr. Katoki has any thoughts on this.
Like, are you asking for differential for a narrow complex tachycardia or
Yes.
etiology of SVT?
No, I'm looking for a differential diagnosis for a narrow QRS tachycardia at 300 beats per minute in a 2-week-old. So we talked, what's the causes of SVT? What is the most common in all kids?
So could be could be ORT or AV NRT.
NRT, right? That's exactly right. See, you knew it. You just couldn't verbalize it. So, right. So, ORT, which is orthodromic reentrant tachycardia, going down the AV node and up the accessory pathway, would be the most common form of SVT in young children, but about a third of SVT can be due to AV nodal reentrant tachycardia, where you're going down a fast pathway and up a slow pathway. Now, here's the high level question. Can we tell whether this is ORT or AVNRT from this tracing? This is the extra credit question. You don't get demoted if you don't get this question right. And you're allowed to ask a senior friend if you like.
No.
Okay. So let me see here if Dr. Condon, Tulsi, do you have any thoughts on how you could make a differential but decide whether this might be ORT or AVNRT? And again, this is a guess, but
Yeah.
this one there's a reasonable. Just gonna sort of point over here. Let's give you a little advice.
Well, I was gonna say the RP interval.
Yeah, I like that thinking. Yes.
If it's less than 70 milliseconds,
It would be consistent with what?
ORT, I believe.
No, actually, it's
It's
just the opposite,
AVNRT. Okay,
AVNRT,
sure.
right?
Gotcha. Uh-huh.
So the way to think about that is that it takes longer to go down the AV node and then up a pathway than it does to re-enter within the. Remember that the re-entry in AVNRT is occurring in the node itself, and so it might even be that the A precedes the V, because the impulse is essentially depolarizing the atrium and the ventricle almost simultaneously from the node, whereas in ORT has to go down the node, travel through the ventricle, the His-Purkinje system, up to the pathway, and then back up to the atrium. So a good general, so that's right. So greater than 70 milliseconds, more consistent with orthodromic reentry, less than 70 milliseconds, more consistent with AVNRT. Now, in the end, it's not really easy to tell the answer to this question, but the general rule of thumb is if you can see the retrograde P wave, and I'm pointing here in V4, and I think actually this does look to me like an extra little inflection on the T wave that looks to me like a retrograde P wave. And this R to P interval is probably about 80 milliseconds. So generally speaking, if you can see the retrograde P waves, chances are you are in ORT, not in AVNRT. That's not a hard and fast rule, but it's probably not unreasonable. And it doesn't really matter in terms of the acute management of this patient, but it's just a nice exercise. We wrote a paper many years ago that I reference a lot where we showed that in lead V1 and lead 3, we often could see the P waves best. Happens that there's a lot of artifact in this ECG in those leads, so it's kind of hard to tell. Okay, so let's go back to Christina. So Christina, you are in the emergency room. You've made the diagnosis of SVT. You think that probably this is ORT. Baby is crying. How would you manage this now?
Can't you do while you're getting medication ready, or first see if the patient is stable or unstable?
Okay, so patient looks okay, is crying, is screaming, little mottled, but basically is, okay.
I think you could first do some vagal maneuvers. With
Okay, and which ice where?
On the baby's head.
Right, on the baby's
And
face. So
yeah.
it's very important to remember that when you're doing a vagal maneuver with ice, you really want to almost smother the baby. If the baby is not like really, really bothered by it, and it should be going across the eyes, the nose, even the mouth. And obviously, we don't want to kill the baby, but you want to do at least 10 or 15 seconds of ice to that area of the face. Okay, so you try that. That's probably the most effective and traditional one. Any other maneuvers you could do?
You can also, I guess, because you want them to bear down, but
Mhm.
in a baby, can you do? Forget like a mm, or like have like a blow by or oxygen or a rectal probe to do a
Yeah,
rectal
so
stim to
some
make them bear
people,
down.
right? Some people will do rectal stimulation. You could do a knee chest. Those are both reasonable. But okay, let's assume those don't work for this example. What next would you do?
And then you could give adenosine.
Okay, and how much would you give?
I think you do start at 0.1 mgs per kg
Yep.
per dose
And
to
okay,
give.
so you give that with a very large and quick flush. So always useful to give it in a as close to the heart type of IV as possible. And you always, in an optimal world, you should do this with a two-way stopcock so that you can give the saline chaser immediately after the dose, because we know it's very rapidly metabolized. So 0.1 fails. What's the next option?
Then you can go to 0.2.
Okay, you give 0.2, and 0.2 might or might not work. If you were going to, let's say for the sake of discussion that there is no adenosine available, any other medical therapies you could try here?
Mm. Can you do amiodarone?
Yeah, you could give amiodarone. There's a lot of agents you could give. You could give amio, you could give procainamide, you could give esmolol. a lot of different agents that theoretically would be used. None of those would be first line agents for this, but probably all of them would ultimately work. And if you were going to cardiovert this patient, how much energy would you give the patient? How many joules per kilo would you give them?
2 joules per kilo.
No, actually for SVT, we would usually start at 1, right?
Okay.
And give 1 joule per kilo. And if that failed, we would then give 2.
Okay.
Nothing terrible would happen if you gave 2. Probably if you're going to make a mistake, better to give too much than too little. But for SVT, we would give 1 joule per kilo. For VT, we would usually start at 2.
Okay.
And then double if that failed. And remember that this would be a synchronized cardioversion, because we would not want to put a shock on a T wave, right? And induce a ventricular arrhythmia. So we would synchronize to the QRS. We would give 1 joule per kilo and cardiovert. And then in terms of chronic therapy, there are many, many, many different options. And depending on where you live, what hospital you're at, who's the electrophysiologist or the cardiologist on, there's as many choices as there are people. I think most people in 2023 would probably start with a beta blocker like propranolol at 1 to 2 per kilo per day. Other doctors might, in some countries, they use amiodarone as first line therapy because it's very easy to dose as a once a day medicine because it has such a long half-life. And the thought is that it basically is only going to be used for less than a year of age. And so you are unlikely to take on serious morbidity associated with its use. So not an unreasonable agent. Some people would use sotalol or flecainide, as we discussed earlier this morning. Some might even use digoxin, not an unreasonable agent for the treatment of SVT. Really just depends on a bunch of different options. Also, a lot of it depends on how sick the child was when they came in, I think, and how reliable we think the family is. For example, wouldn't necessarily give flecainide to a child whose family doesn't seem, parents don't seem very medically aware because of the concerns we discussed with overdosing, things of that nature. So anyway, okay, so I think at this point we're going to stop. We've gone about 30 minutes. Thanks very much. Hopefully we'll be back next week again, and hope everybody has a great morning. We'll see you later, guys.
Thank you.
Take care.
Thank you.
Bye.